Okay, so we are going to draw in all of this morning's speakers. There we go. That's starting to look good. Just in case any of our wonderful tech does give us any feedback, just be aware if we start getting an echo, we may need to be disciplined on the mute button. So I'm going to move to the questions and answers. Sorry, those of you in Welsh Government will know that when somebody has a chat going on, it comes up and blocks everything you want to press. Okay, so I'll just start with a question to Helen, really. Vanessa Hayward has asked, should we be doing more to give our people the skills to put compassionate leadership into practice and encourage gentle feedback when we see this is not happening?
Oh, wow. Oh, that almost certainly. Absolutely. So there's a few things that we are doing to try and help there. We are creating resources that we will share with all organisations. So in all of the leadership, in all of the management programmes, we'll start to bring in compassionate leadership, compassionate behaviours and the art of giving feedback, because compassionate sometimes sounds, as Michael might say, fluffy cushions and candles, but it's very difficult to give feedback to individuals in a compassionate way, but effective way. And some of those behaviours we had about listening and talking and understanding the situation will certainly help there. We'd also have on the undergraduate curriculum for health and care in Wales, compassionate leadership. So that would be brought through all of the curriculum. So we'll start, if you like, at the beginning to bring into the health service the leaders and the attitudes and the behaviours that we need. But we have to work with the current people as well, and that's going to be a long job. It's not going to happen overnight. But if we provide the resources and support the organisations and embed it, we have to make systematic changes and not just, leadership opportunities. We need to change the recruitment processes, the appraisal processes, to ensure that we are ensuring our leaders are behaving effectively and that we can call that out if not. We're also creating a number of evaluations or questionnaires, 360 degrees, for example. So we've got what we know are the compassionate behaviours, and there's statements under each of the behaviours or under the principles. And the statements will tell you what good looks like and what good doesn't look like. And we're converting that into some sort of 360 and self-assessment, so we can share that with organisations. So as part of appraisals you may want to do, or as part of your own development, how well am I being a compassionate leader, and let me have some of that feedback, and that will indicate some of the gaps there. And again, these resources will hopefully provide some solutions. So long answer, definitely yes. And we just need to move into that direction and provide the support and resources for our managers and leaders to be able to do that safely and competently.
Oh, fantastic. Thank you, Helen. And following on from that, there's a question from John Day to both you and Kieran. So how do we develop research-capable leadership in our professions? And he's specifically asking about research leadership and how that's featuring in leadership development programs.
Do you want me to go first, Helen? Yeah, okay, I will. So what does it look like to have a research or an organisation like a health board or a trust that's really research engaged, really research savvy? I think it starts at the top. So you have to ask yourself, do the people on the board understand research and innovation? In an enterprise the size of one of our boards, in any other sector, you would have on the board both someone who has a corporate responsibility for research and innovation, but you'd also have professionals who have that research background. In a motor company, you'll have engineers on the board. In an IT company, you'll have people who've spent their whole career in the IT profession on the board. So I think we need to think about getting great competence around our board tables, both in the executive and also in the non-executive members of boards. Seeing the board as really leading from the top on research engagement. It then works its way down in the organisation. And we in our annual discussions with every board and trust, we try to hold their feet to the fire a bit in saying, what are you doing to make yourself a research savvy organisation? So asking some really fundamental questions about the opportunities they provide for professionals from all backgrounds to get engaged in research. There's a really interesting idea from the Academy of Medical Sciences, which I think people have latched onto, what they call the 2020 rule, which is that 20% of our healthcare professionals should have at least 20% of their time set aside in their job plan for engagement in research. I think that is a fantastic target. We are nowhere near that. Indeed, in asking the question in many boards, we don't really know how much time is set aside for people in research in their job plan. We have to keep hammering away at saying, if you give people research opportunities, it makes it easier to recruit. You know, you're recruiting to jobs where you're not simply saying, come and work 5 days a week doing nothing but service delivery and we'll work you to the bone, but you're saying, come and work and also engage in research and innovation, which brings payback for the organisation in terms of job satisfaction, but actually also in terms of improving services. We know, you know, the research shows us that research engaged organisations provide better quality care and are more productive. So we've got to kind of play all those arguments out from the top. Thinking about the professional groups, I think we need to build into our education for professional groups stuff around research policy and research leadership. So in fact, in England, because I'm at the University of Manchester, I teach on, or have been teaching on, the national programme that's been set up for healthcare scientists there to provide a professional doctorate. And there's a chunk of that that's provided by the business school in Manchester and is all about leadership, research policy, improvement science, and a whole bunch of technologies like that. And I think that's absolutely the set of skills that we need to be able to be giving allied health professionals and healthcare scientists for them to progress in leadership, and indeed to progress in leadership outside their own disciplines. Over to you, Helen.
I've got nothing to add to that, Kieran. I think you comprehensively answered that for me and got me out of a hole. So thank you for that. I hadn't really given any consideration to how we build that in, but there's certainly some work to do there. I'm happy to link up.
I think that cadre of consultant scientists and consultant physiotherapists and you know, the consultant grade is really important in the future and the way in which they're equipped. And
I think that's absolutely right and critical. And I think, you know, sadly, what we've discovered in talking to some of our consultants over the last year is that actually, well, I'm going to extend that. It's not over the last year, it's over the last couple of years. So it is outside of the pandemic times, but actually that the pressures that they face in many of our services can mean that this becomes the bit that is squashed out of their practice. So even when they're ready and able and theoretically have it in their job plan, the pressures of every day and the culture that we have in our organizations can mean that actually it's seen as the bottom of the priority list. So just to draw in on the back of that, a couple of questions that I'm about to mess up, Sarah and Mark, but following on from that is a question to you about how do we ensure this is woven into everyday practice, and how do we ensure that people do see it as everyone's business and as key business for everyone, not just something that gets done only after you've worked with the patients? I don't know who'd like to take that one.
I'm letting Helen go first this time, but I do have a view, of course, but I don't know if Helen wants to speak first about that.
I don't, Kieran. I'm more than happy for you to take this first.
Yeah, I mean, the thing is, it's easy to say, it's hard to do. You know, it's very easy to say 2020 should be the rule, and then if you're working in a board, if you're running a clinical service, the reality is that you've got waiting lists, you've got patients to see, there are huge pressures and so on. The challenge, I think, not just for us working in research, but also for people working in innovation and improvement disciplines, is to help people to create the space and time to allow them to do these things. And some of that has to begin by focusing on things like productivity and efficiency. So if we can help people to find research innovations and improvements which enable them to improve productivity and release some time. So if you think about some of the sort of releasing time to care type programs that we've seen in the past, those are ways into that very difficult set of issues. But it goes back to Helen's point about leadership. It needs leadership, and leadership from the top. So in boards and trusts, the person on the board responsible for research and innovation is usually the medical director. And I think we have to hold those medical directors and their chief executives to account for recognizing that it's not just about delivery, and that in the short term, if you make everybody spend their whole working life deliver care, you'll get more care out of them. But in the long term, you are stacking up a set of problems about burnout, about turnover, about morale, and actually about efficiency and productivity, which will come back to bite you in the longer term.
Just to add to that then, from how do we make leadership everyone's business, as our chair said on the video, it's about starting in many directions, I think. Yes, certainly, it's definitely at the executive level with the board. They set the culture. What they pay attention to is what becomes what we pay attention to. And that creates then that culture. So if they are paying attention to compassionate leadership, if they are creating the conditions that they propose shared leadership is the way to go, if they promote the fact that we need teams that are empowered, engaged, if they're promoting the fact that well-being is critical to health and well-being, then what they're paying attention to and what they're walking, if they're walking the walk, will start to become that culture, and we can start to improve how we change the culture, but also how we reflect that leadership is everyone's business. And I mentioned we have several ways. We're starting with the undergraduates. We've got graduate programs, we've got internship programs. We need to influence at that level, so those coming in will also add to the culture. So it's top down, bottom up, and then we need to address in the middle as well. And that systematically needs to change through our people processes also. So there's a number of avenues we really need to address this on.
Thank you both. And I'll just pick up one last research one before coming to the digital questions. Kieran, I think everyone was very interested by your description in terms of the prioritization and some of the access to funding, which we know is a challenge. So John Day has asked, how do our professions influence the research prioritization agenda for the ultimate benefit for our patients and services?
Always nice to finish on a really easy question. So I think the challenge for research funders is that when you ask about what the research priorities are, the loudest voices are usually those in the research community. We've seen that. I alluded to that in my presentation. In the COVID response that UKRI ran, what we've seen is 1,000 flowers bloom, with loads of ideas coming forward, largely from existing research teams. So if you were researching diabetes for the rest of your professional life, what you came forward with was ideas about research on the impact of COVID on people with diabetes, which is all well and good, but that's not necessarily what, if you were asking policymakers and patients and others, what would be the priorities, the things they would choose. And you know, that there is a long history to understanding that you get very different answers to the question, what are the research priorities, if you ask the academic and the research community or industry versus if you ask patients and clinicians working in service delivery. So we work quite hard to try and understand the research questions from the point of view of service users and service providers. We haven't in the past in Health and Care Research Wales had a strong commissioned arm to our research funding. So most of our research funding has been driven by submissions rather than by us issuing calls. And I think COVID has been a bit of a shift in that. We've recently been working with colleagues in Social Care Wales, and we've developed and piloted a rapid prioritisation process, which we've run for the first time this year. And that has taken a topic area, which was social care for older people, and worked with Social Care Wales, with patient groups in Wales, with research funders and others to develop a set of priorities. Those priorities have gone into the funding activities of ESRC and of the HSDR programme that NIHR runs and which we buy into. And it's been really gratifying to see, you know, the ideas that have come from Wales going into those much larger funding streams where Welsh and other researchers can apply. So I think that's part of the answer. We need as funders to try to be much better at understanding the research needs of both people working at the ground level in the NHS and in social care, but also of the organisations. If you think at the moment about what are the big problems, surgical backlog is a huge issue. Well, the COVID-19 Evidence Centre is currently doing a rapid review around surgical backlog and interventions to address surgical productivity. And I think that's the kind of stuff that we can do that then, going back to boards, they look at it and they go, that was actually really useful. And that's the most powerful way of demonstrating the value of research.
Fantastic. Thank you ever so much. I suspect you're about to generate a flurry of either questions or emails from many of the HPs online to understand how they can participate with some of the projects that have been started, but are quite small scale in terms of supporting that that surgical action. So Leon and Philip, thank you for waiting. There's a really lovely question here from Mark. We've embraced using digital innovations over the last 18 months. And he asks, there's been a stratospheric use of digital in Wales. Do you think that's plateaued by clinicians and service users? And I guess I would kind of add to that. Do you think people might start stepping backwards?
So I'll come in here if that's okay. And my answer will be no. But I'll explain that with two tangible examples. I don't think it's plateaued, and within that, I think, is there an element of fatigue? We need to concern ourselves with the fact that if we're changing the way we work dramatically, transformatively as well, what is the capacity for the workforce to absorb this, to understand it, to incorporate in ways of working, as well as doing the core elements of the day-to-day job? And so fatigue and understanding how we roll out change and the support for the individuals, I think, is key to ensure that that fatigue is short-lived, if not eradicated. The two examples I give is, when I joined Welsh Government, I was very lucky to follow a consultant urologist, Rydyn Hurl, who's from DHEW and is also in Prince of Wales Hospital as a consultant. And I had a unrivaled experience in being with Rydyn and talking with patients, being within in the operating theatre, but also in the overarching, the encompassing minutiae of the troubles of the paper legacy systems. And honestly, when I walked into the library at Princess of Wales Hospital, it was really like walking into a library in Harry Potter. You couldn't see the back walls, you couldn't see the side walls. The amount of paper that's required to effectively deliver safe patient care. There must be better ways of doing this. One, to ensure that it's at the fingertips of the medical professionals delivering point of care delivery, but also in terms of reassuring the individual that it doesn't matter which hospital they're at, it doesn't matter which GP surgery they're at, it doesn't matter to an extent which part of the UK they're in. If they need care, they're probably upset, they're probably distressed, they're probably worried. They just need to know that the person treating them knows everything they can about the individual. And so therefore, I think there's still further we can go in ensuring that digital services can deliver a better care. One last bit regarding plateauing perhaps in users. If I talk about NHS COVID Pass, for example, to date, we have printed over 146,000 paper passes since July for people to use for domestic settings and to go abroad on holiday. That part of that is down to people that, well, yeah, I'll get a digital app, I've got a smartphone, but isn't it safer? Don't I feel more reassured that I've got a piece of paper in my pocket? But then equally, we're getting numerous queries, complaints from members of the public, MPs and ASA saying, England's got an NHS app. Why am I being treated as a second-class citizen? This is the UK. There should be one approach to supporting me and my colleagues as well. So with those two examples, there's much more to be done in terms of delivering better services with a digital transformation lens, as long as we're considerate about what that means to the people using it and also for those people benefiting from it as well.
And if I may, just a plug on some of the work by the National Pathology Programme. Certainly, I could see clinicians really embracing the Digital Pathology Programme. And for those who don't know, it's all about trying to digitalize glass microscope slide preparations to a really high level of quality, so the slides can be viewed and reported using digital images. And the feedback we've got on the early success of the first phase So certainly, it was a proof of concept, and people recognize we were able to eliminate many of the physical and time-consuming steps involved in transporting these slides to pathologies and the multidisciplinary team for review. So I think people could see the opportunity. So I don't recognize that statement either. Thank you.
Okay, thank you. I think there really has been such a significant amount of work, and the NHS Innovation Study has captured some of those really quite outstanding actions that the whole workforce across the NHS, but we have separate chapters in there, one for the allied health professions innovations and one for the healthcare science innovations. And I think we're the only let's grab the credit while we can. We're the only two professional groups who got separate chapters on their own, and there is a significant amount of work that we've done. And both the framework for healthcare science and for allied health professionals are very clear about our need to move into more digital ways of working. There is one last question, and I may have time for two, depending on how long your answers are. But the first question I'm going to go to then is one from Wendy, in terms of how do we make these careers more accessible? So how do we help our workforce to move into careers that are more research based, either research in their career or a research career, but also to be part of that innovation and those innovation opportunities that you, Philip and Leon, also talked about, so that we are getting much more of that evaluation and research in terms of our service focus. If that question made any sense, I was trying to collate far too many together. So I don't know who wants to go first.
Shall I pick it up in terms of the research career point? So that's absolutely been the focus of the review we've been doing over the last few months with colleagues from HEIW and Social Care Wales, looking at research career pathways. And what we've done is a big survey and some mapping, and we've also looked at how it works in the other 3 countries of the UK. And that report, I hope, will come out in December or January. What it essentially does is make a whole series of recommendations for things we need to change to make it work better. Some of that is about presenting the opportunities that already exist more coherently and organising them better. And one thing we plan in Health and Care Research Wales to do is to set up an organised faculty that brings our existing schemes together and has some leadership which both leads those schemes, but also, this is really important, makes sure we're properly well connected into the funders of those opportunities that exist at a UK level. So that's the research councils, it's the Wellcome Trust, it's other charitable funders and so on. So that's one part of it. But the other part of it is really we do need to invest more, spend more money. So if I give one example, at the moment, we run a PhD scheme which provides a stipend. It's just not feasible for somebody who's got a mortgage and a family to get a £15,000 a year stipend for 3 years and do a PhD. So we need to have what you have in England, which is a salary funded PhD scheme. That would be a really important entry point. And in doing all of this, it's a bit like football. You want to invest in the grassroots so that people have opportunities, and then you want to see those grassroots through what is often a quite brutal selection process, funneling up so that we get the research leaders who are going to be the future kind of big hitters in research terms in Wales in 5 years or 10 years or 15 years time. But if you don't invest in the grassroots, you're never going to get the big hitters.
And Ruth, if I come in, I talked to you about people being at the heart of our success, and I also went further in indicating that Wales and digital transformation in Wales should be a career destination of choice. We need to do more work, particularly in civil servants, in that the way that we write our job descriptions, which really is the shop window. It's really saying, hey, you, look at this, isn't this exciting? But when you read the job description, when you read page 4, when you go through the list of experiences and capabilities, and then when you come to an interview and really it's a tick box exercise, we need to be more innovative and agile on how we write job descriptions to attract the right type of person to come in and work here. We're not looking at people that work well in teams. We're not looking at people that work well in team settings. We're looking at people that are more flexible, that can adapt, because the new ways of working will never be established. We're not quite sure if we're returning wholesale back to offices, or if it'll be a flexible approach of dynamic working in an office or at home or in a coffee shop, or having a call whilst you're walking along the seafront. These are new ways of working, and so we're also looking at new hooks that attract people and hopefully keep them in and develop them. Because the point that Kieran makes there about attracting people, we need to retain them. We need to give them meaningful and challenging jobs that are still exciting in 15 years' time, not just on day 15.
And just to add to that, we recognise more needs to be done in this area, and the healthcare science in NHS Wales Looking Forward framework has committed to us really providing a research mentoring and development scheme for healthcare scientists throughout their careers. So PhD is great, but actually, it's about at all levels as well. And just to help people to engage with research and innovation activities, just because we recognize it's not easy to sort of just get straight into it and in a competitive process. So yeah, watch out for this space.
Fantastic. Thank you ever so much. Helen, there's one last question we haven't reached, which is about the Tier 3 leadership development. I'm conscious we are technically out of time, but if you want to just give us some very quick information before we break for lunch. Sorry, that's the kiss of death, isn't it?
Sorry, I couldn't get to my mouse quick enough then to unmute myself. Tier 3 leadership, yes. So we are responsible for Tier 1, 2 and 3 leadership, and our focus has been to date on Tier 2 leadership, which is executive directors and directors. So the feeder tier, if you like, below that, we are now exploring how we can do that and what we're going to bring in. So we haven't got any defined and agreed processes yet. Many of you might have heard of this senior leadership experience, which was previously run by the Academy Wales. What we're looking to do is join forces with Academy Wales and with people across the service who is able to support and run that, and run from next year 4 cohorts a year of this senior leadership experience, which is really about diagnostics, understanding the skills that you have yourself, and then we can explore your skills against the skills we need. Philip talked about job descriptions there. What we have created is an executive success profile. So what are the skills and competences and behaviours and traits needed for executive leaders to take us into the next 5 to 10 years? And we need to bring those down now. We've done it for executive leaders. Let's create one for Tier 3 leaders, and then we can look at the journey and how we support individuals. So we've got some ideas, we've got some things in train, nothing that we can actually say that this has been signed off yet, but that is our next IMTP objective really. How do we support Tier 3? Have some ideas and look forward to sharing these wider as soon as we get some approval and funding.
Oh, that's fantastic. Thank you. I want to thank all 4 of you so very much. That's been an absolutely fascinating morning. Lovely discussion to finish with. Really, really exciting. I know that you will have an equally exciting afternoon this afternoon. So you can now have a break for lunch, fresh air, bit of movement. Get up off those chairs, and please return for 12:30. And those of you who found your reaction buttons at the bottom, it's wonderful to see the applause. So diolch yn fawr for all our speakers. Thank you so much. Have a lovely lunch and rest. See you at 12:30.
Diolch, Hwyl.
Diolch, Hwyl.